Okay, so we'll discuss heat and cold related illnesses. Start with prevention. The topics included here are heat stroke, heat exhaustion, and then hyperthermia. Let's start with prevention first. So who are at risk for heat-related illnesses? So we have our elderly, those who are our utility workers, our homeless neighbors, our impaired individuals, alcoholics, drug users, or athletes. Okay, so especially those who are winter or outdoor athletes, because it'll be the same people actually for heat related and cold related illnesses. I mean, you can read, I'll let you read these. Stay hydrated, wear appropriate clothing. Chart 67-6. Okay, so let's start with heat stroke. There are two types of heat stroke here, non-exertional and exertional heat stroke. Sometimes patients will have both, especially when we have marathons in the summer. So that's both. Patients are at risk for both exertional and non-exertional heat stroke. Heat stroke is a true medical emergency. Now, the other form, which is also induced by heat, is called heat exhaustion. Heat exhaustion is simply dehydration caused by heat. Heat stroke is the true life-threatening emergency. Heat exhaustion, that's any one of us can experience heat exhaustion, which is again, what is heat exhaustion? Dehydration caused by heat. Most common or most affected people are, of course, the elderly. So let's look at signs and symptoms. Heat stroke, regardless of the cause, these are the manifestations. First, the body temperature is over 105. So 105, there's really no limit as to the top number. Can go to 111. So here are your manifestations. So in addition to the obvious dehydration that occurs, the lab test we see in any dehydrated patient, which will be, what will be the H&H? If you're dehydrated, high. What would be your BU and creatinine? High.
Yes.
Your vital signs will be, heart rate will be, blood and blood pressure will be. Okay, so those signs and symptoms. And now the patient will have headaches, anxiety, changes in mental status, including syncope, profuse diaphoresis. Now, it's not true that heat stroke patients stop sweating. Even in the absence of, even in heat stroke, the patient may continue to sweat. And the severe electrolyte imbalances will lead to, of course, muscle cramps. And this can also lead to non-traumatic rhabdomyolysis, okay, which can lead to kidney injury. Yeah, the connection keeps getting so let's go to management. Of course, this will comprise two sets of interventions, because most likely, well, where will this occur? Will this occur in the hospital or out in the field? Okay, outside, either in the home if it's non-exertional, or out in the field if it's exertional heat stroke. So what's the first aid? So we have BLS, right? So what's the, is it ABC? No, CPR. So it's CAB now, right?
Yeah.
Okay, so you do first aid wherever, because these patients can go into cardiac arrest. First, if the patient is stable, no cardiac arrest, then we start cooling them at the site. So first step is to remove clothing. So only the underwear will be left. Patient will be cooled by, what are the ways we can cool? Conduction, which is fanning, right? And then we have conduction. Yeah, we cool them, put cold towels in the areas. Okay, cool the patient down. How else? Radiation, correct? Will we use Tylenol?
We could IV, right?
Do we give, does this respond to Tylenol?
No.
No, this is different, okay? So pyrexia, which is fever, is not the same as hyperthermia or heat stroke because, correct. So let's say the explanation is we have a thermostat, correct? Our body has a thermostat. So our thermostat is set around what? 97, somewhere there, 97, 98. That's our thermostat. In heat stroke or in hyperthermia, the set point, the body's thermostat did not change. It remained at 97, 98. We just can't cool ourselves down because the temperature is just too high. The body's heat loss mechanisms can't bring it down independently. So that's why we use these. These are the ways we cool the patient down. Tylenol will not work because Tylenol is only used if it's infectious in nature, meaning if the pyrogen, which is what we call a fever-inducing organism, correct? If you have an infection, if you have a pyrogen in your body, the pyrogen changes the body's set point. Instead of 97 and 8, now the thermostat is now at 101, 102. So if that's the thermostat of the body, can the patient lower it below 101? No, because the body is thinking that's the thermostat. So therefore, the body will stay at that temperature. Okay, so you see, what do we do when patients have a fever? Besides these, we also give antipyretics because we have to change the set point. Without antipyretics, without Tylenol, ibuprofen, without these fever-reducing agents, we cannot change the set point. Does that make sense? Okay, so it's different here. The set point remains normal. It's just the body temperature cannot. I mean, the patient's heat loss, our body's heat loss mechanisms cannot bring it down. It's way too high. Okay, because that's why it's called heat stroke, either exertional or non-exertional.
Drinking water.
Well, that's part of conduction, yes. Was that a question or? I really didn't see a question.
Oh, I was asking if the patient, I thought you answered it already, but I was asking if patients drinking water.
No, not at 105.
It helps the core if it's cold water.
Yes.
I usually so like when we were reaching like super high temperature. And I got floated to ICU, they use like an Arctic sun. What?
Not familiar with that device, but is it a cooling blanket?
It's, yeah, some sort of machine.
It's basically for conduction.
Okay.
So these are the methods. We cannot use Tylenol because it will not work. Okay, because this is a different type of heat. It's not caused by a pyrogen. Okay, so only these measures will help. If needed, if the patient doesn't respond to external cooling measures, we can institute internal cooling. First is we can put ice saline. Ice saline is nothing more than a bag of saline wrapped in ice. That's it. So we cool the patient down. So IV fluids will be cold when they enter the veins. We can also, what? Yes, it will cool the patient inside. We can also put in a Foley and then irrigate the bladder. No, with cold water as well. No, not cold, not water, but cool cool saline also. So we irrigate the bladder. We can also put in a rectal tube, put in cool water as well, or NG tube, lavage the stomach also with cool liquids. Okay, so those are internal cooling measures.
Cold, saline, or thin ice, or fit the blood capacity.
No, I mean it'll just cool the temperature down. Now we stop the cooling measures when we reach about 102. Okay, because at 102, the body can handle that now. Okay, our own heat loss mechanisms can handle 102. So we stop the aggressive internal cooling once we reach 102. No, sorry. That was for malignant hyperthermia. Sorry. For heat stroke, the threshold is 100.4. Okay, sorry, I'm way ahead. So 102 is for another condition. We'll get to that after we finish heat stroke. Okay, so for heat stroke, what's the target? 100.4. And then when we reach this, we stop. Okay, stop cooling. It's enough now. Because otherwise we'll have another problem. Patient will start shivering, and then we're producing heat now. The patient is unstable here, hemodynamically unstable, so you give fluids, put them on a monitor, treat the electrolyte imbalances as needed. But as far as the heat, as far as cooling the patient down, those are our treatments. Okay, so these are the measures we use to cool them down, and then we treat the symptoms. If the patient goes into dysrhythmias, we treat that. Can they go into AKI?
Yeah.
Yes, because they're severely dehydrated here. So we treat the AKI and so forth. Okay, it's not going to be discussed everything here because they're discussed in other chapters. Okay, and oxygen, of course, because there's mental status changes here. Plus, not to mention, what's the pH here?
Acidic.
Very acidic. So the patient goes into metabolic acidosis here, you treat that as well. As already mentioned, the patient goes into AKI, so you treat the AKI. Or if the patient, which is not really common, the patient may go into DIC because this is a severe injury.
Yes.
Patient goes because the temperature of 105 or higher, that can trigger seizures. So imagine the intracranial pressure at that point. So patients will go into seizures, so institute seizure precautions. We already finished seizure management last semester, so it's how do we stop seizures? Benzodiazepine, so lorazepam, and then you institute, you give Keppra or levetiracetam IV. And to suppress shivering, we give chlorpromazine. Yeah, that's about it. Question? If it's heat exhaustion, we still cool the patient down. However, the patient's main problem is really dehydration. Then they could go into acute kidney injury as well. So that's the only difference here. But at least heat exhaustion is not life-threatening. This one, the heat stroke is due. Okay, this is an emergency. Let's go to cold-related illnesses now. Top of the list will be frostbite. Same thing. Did you know you remember the concept of burns?
Yeah.
Okay, so if you know the concept of burns, this is the opposite. However, this can still injure tissues just like heat would. So heat or burns can actually have the same effect if it's below 0. Okay, so it can still have the same effect as burns. However, the appearance might be different. But the tissue damage is exactly the same. What's the first level of frostbite? We've all experienced this when was the last time we really had a cold? It was like 2018, right? 27, that's the last time I remember. I know because my pipes blew. My house was not livable. Okay, all my pipes burst. January 8th.
Yeah.
2018. I'll never forget that day.
There was a day last winter was the coldest day. Something was, I don't know what happened.
Yeah, but it didn't reach like 10 or
No, it
10
was
degrees.
-10.
Really?
One single day. Yeah, it was first all my pipes like.
Ah, okay, good for you. Your turn.
Okay.
So the prevention the same. So because the risk factors, the persons affected will be the same. So cold, weather, hot weather, same persons affected. Clothing, what type of clothing will we use? One or several layers. Okay, it's always several layers. And what material? Cotton? Okay, not cotton, it should be. Well, the material now is Gore-Tex, right? It's the same thing as used by Under Armour or Uniqlo. You know those synthetic yeah, that wick moisture. Yeah, they wick moisture. They don't retain. Cotton retains moisture, so that's the recommendation. So gold, if it's too hot, we cool them down. This one too cold, we warm them up. So put them back to body temperature. So we remove these to promote circulation. Wet clothing, remove. So the same as with heat stroke, heat exhaustion, we remove the clothing.
Is these two topics part of hematology or?
Now this is under environmental thermoregulation.
Okay, then remove the clothing.
Okay. When we thaw the frozen part, so let's say a foot, a leg, your nose, your hand, fingers are frostbitten. Look at the temperature of the water. 104 degrees. It's pretty hot, right? So this is the temperature that you dip them into. For 30 to 40 minute spans, we stop it because it will have a rebound effect. So only 30 minutes at a time. Stop and then wait a few and then thaw them again. Now the concept here is, so let's say the scenario is the patient is, this is frostbite. So let's say the patient's up in the mountains, then we rescue this patient. But let's say there's no available helicopter. So the patient will be transported by ground. If there's a chance of refreezing, we do not bother with thawing the frozen body part. Because once you thaw it, it can't be allowed to refreeze because now the tissue is gone. I mean, you've seen steak, right? That was frozen and then you thaw it and then you freeze it back. It's no good. You can't eat it anymore. So same exact concept. So if there's a chance of refreezing, do not thaw the body part. Leave it frozen. Start thawing when we're in a more secure environment. The thawing process is very painful, so make sure you give opioids first. No massaging, just leave it in the hot bath, right? No massaging. Don't add any more muscle damage. So this is what I mean earlier. So do not allow it to refreeze. Okay. Same as burn injury, what happens to potassium levels during the first few hours? Okay, hyperkalemia. So same idea, no different from frostbite. And here are our the rest of the interventions. Once we reach the hospital, this will be done. So we have whirlpool baths now in the hospital. So they will immerse them in these baths, granting there are no infected wounds. Escharotomy or fasciotomy. No different, right, from burns. So same idea. So when we have circumferential frostbites, circumferential burns, same idea. So we cut it to prevent compartment syndrome. Discharge, avoid any vasoconstrictors. We want to promote circulation. So vasoconstrictors include coffee, smoking. That's about it. Questions? This here is the same. I won't discuss it separately. But I want us just point out never mind. We already talked about the temperature. It's up to 104, right? The temperature of the warm bath. Let's go to malignant hyperthermia. This one is under
All of these topics.
and exam.
One question on it. What's next, like eight topics? No, kidney transplant, SLE.
Addison's and Cushing. No, the next.
Next is lupus. Transplants,
And frostbite and hyperthermia.
Okay, so this is the last topic for today. This one is under perioperative chapter. This is chapter something. Chapter 15 under intraoperative nursing. It's here because this is a anesthesia complication. So this is a reaction. It's genetic. It's a genetic disorder in reaction to general anesthesia. Now, what anesthesias are known to trigger this? They are, it's a list. Right here, page 432. So the anesthetic agents associated or known to trigger malignant hyperthermia are allothane, enflurane, isoflurane. And succinylcholine is not an anesthetic though. This is a muscle relaxant or muscle paralyzer. So we use these during surgery. We not only knock you out, we also paralyze you. Okay, we give you muscle relaxant. Your whole body is paralyzed, including your diaphragm. That's why you are intubated when you're having general anesthesia.
To prevent the tremors or?
No, we paralyze you so that you don't move. Because when we're cutting you, we don't want you twitching or scratching your nose or scratching the operative side. Does that make sense? Okay. I mean, it makes sense, right? We have to paralyze. We can't allow you to move. Does that make sense? You're paralyzed. You're probably.
It just helped with the pain anesthesia, and this is for the.
Yes, yeah, this is to, well, you're also getting opioids. Okay, so there are 3 sets of medications. Yeah, so we knock you out, no consciousness, that's the anesthesia.
May feel pain.
Right, we paralyze you, and then we give you pain medication. Right, so totally painless. Okay, you're not aware of anything. You come to later. All right, so I mentioned this is genetic, so it's inherited. It's rare. The trigger again is the anesthesia. So when you're exposed to anesthesia, the reaction occurs. So the reaction affects muscles. So the muscles react to the anesthesia, causing endless non-stop muscle contraction. Now, how does the body produce heat? Through muscle contraction, right? So if you don't move, you cannot generate heat. So that's why we shiver, correct? So then that generates heat. So imagine a non-stop, every muscle in your body from head to toe contracts and doesn't relax. How much heat will that generate? Temperature here can reach up to 111 degrees or even higher. 111, enough to fry your brain. So we can fry an egg, we can fry your brain at 111. Other triggers are the following, but they're not very common. The most common trigger is anesthesia.
People survive that.
Yeah, it's rare, but we are equipped. All operating. Who works in OR here? Any surge techs? You're a surge tech? Okay, so you prepared a malignant hypothermic kit, right? You've set that up or no?
I think as the shower.
Okay, but you see it around, right?
Yeah.
Yeah. So in that kit will be everything you need to manage this. Now, not all people get to use that because this is extremely rare. You could go through your whole career without ever seeing this thing. Okay, so it's extremely rare, or maybe it happens, but not on your shift. All right, so it's extremely rare. And the contents of that kit expires, we replace it. That's how rare this thing is. But we need that kit because it's required by Joint Commission. And of course, we have to be ready whenever this thing happens. It's easily preventable through an interview. So if we do our pre-op interview thoroughly, we can find the risk factor and then prevent it altogether. The problem is if the patient has no history, meaning the patient's not aware of any family history, because this is inherited. So if a grandfather, great-grandfather, let's say at this point, or let's say in the 80s, of course, there are no records, right? The records aren't very good. Depends also on which country you're from. So we have no idea about a history. So we answer as best as we can. We say no, when in fact, you have a history in your family. So it doesn't have to be a parent. It could be an aunt, it could be a cousin. Yes,
So you only know you have this
if it happens.
if it happens on the.
Yes, there is a genetic test. However, it's expensive and most insurance companies will not pay for that. I mean, how many surgeries do we get? It's an expensive test and it's very rare. So is it worth it to test everybody? No. So the question on the pre-op under when you get to anesthesia is one of the questions will say, did you or a family member have received general anesthesia? And then if the answer is yes, the next question will pop up. Was there any reaction to anesthesia? It doesn't matter. The question won't specify what reaction. As long as the answer is yes, that means you're at risk for malignant hypothermia. So if the answer is yes, and we identify you have a risk, are we going to use these?
No.
No. We avoid this, we avoid this. Okay, because you have an identified risk. So we don't take the chance, we use something else. Now, question might be, why not just avoid these? Well, we can't because these are the most cost-effective drugs out in the market. We can't just use the expensive alternates because again, it's very rare and these are the most commonly used. Okay, very effective. So we only use something else if we identify the risk. Okay. Right, so here's the what we do. Okay, so we ask for a reaction, history of a reaction. If it's yes, then the doctor, the anesthesiologist is notified. It pops up on the record that, oh, the answer was yes. So he knows to use something else. He or she will be using other anesthetics.
They have a temperature very often. They're probably responsive.
Not all the time. Okay, so let's look at the reaction now. So what exactly happens? So after exposure to anesthesia, this can happen, by the way, at any point. So it can happen right after induction of anesthesia. You know, as soon as we put the mask over you and start giving you the gas, the reaction occurs, which is the best time because we haven't cut you yet. It can also happen right there during the surgery or after the surgery. When would be the best time? Okay, right there on induction, right? Because we haven't cut you yet. That would be the best time. So what happens is the reaction starts in the skeletal muscles. So every single muscle in the body, as long as it's a skeletal muscle from your scalp all the way down to your toes, contract nonstop. In fact, If you raise this patient's arm like this, it will stay elevated like this. It will not go down. That's how stiff the muscles become. And then again, like I said, the rigidity is the first. However, will you notice it? Because the patient is laying still, right? They're paralyzed. So will you notice the rigidity?
Yeah.
No. What we will notice is how much oxygen is this contraction going to consume?
A lot.
A lot. So what will happen to the oxygen level? It will drop. So therefore, who's the first operating room staff that will notice this? The anesthesiologist or the nurse anesthetist, because he's watching the monitor. There will be an unexplained drop. Why is the oxygen level dropping? And of course, what will happen to the heart rate once your oxygen drops? It will raise your heart rate. So that's the first two they'll see. Uh-oh. And then they'll check the patient, they'll check the muscle, and then the temperature. So once they see the changes, if still possible, they'll tell the surgeon, can we stop the surgery? If not, then we'll have to manage it with the incision open. So let's go to, let's finish the manifestation. So again, what's the earliest manifestation? Hypoxia, and then followed by unexplained tachycardia. And then there's, of course, the low oxygen will trigger the rest. Sympathetic nervous system will be stimulated,
Greater than one.
right? So that will result in all of these. Again, the earliest is the
Hypoxia.
hypoxia, which means your CO2 level will
Drop.
rise. CO2 will rise, oxygen will drop, right? So the temperature will start rising here. Now, the management, of course, will be get the
Metabolism decrease?
what?
Metabolism.
No, it's increased because
No, so the management.
the what?
To decrease the metabolism.
Correct. Yeah. So we will decrease the temperature. So the first action will be we'll call for the malignant hypothermic kit. Everything we need will be in that kit except ice. So just add ice. Okay, just like the Chinese soups, just add one egg. This one, just add ice. Okay. So what's in the kit? First is the drug, the wonder drug, dantrolene. Dantrolene sodium is the only FDA-approved muscle relaxant. It's also a muscle relaxant to stop the reaction. So first drug given is this one, and then we begin cooling the patient down because we're not going to wait until the temperature goes to 111. We start cooling the patient. So ice will be placed. Remember what we did in the cooling for heat stroke? Exactly the same thing. So that's external, and then we do internal. Yeah, so ice, saline. Okay, so cooling measures. Now, in addition, what will happen to the muscles if they contract and never stop? What will they produce?
Lactic acid.
Lactic acid, what else? Potassium, right, will rise. And will there be some myoglobin?
Yeah.
Okay, so this patient will go into AKI, correct? Because of, yeah, this will cause intrarenal AKI. So we start giving massive amounts of fluid, icing that fluid. And then what do we do with the hyperkalemia?
Re-examine with the-
Calcium, what? Gluconate and insulin with dextrose IV, right? Right, so all of those interventions will be given. Do we need a Foley? Yes, if there's no Foley, we'll put a Foley. We need to get we need to monitor urine output, the status of the kidney. And then cooling. So it's gonna be busy. Okay, so we're busy cooling this patient down, managing the hyperkalemia, treating the AKI that's ensuing. And hopefully this patient survives, then we can move on with the surgery. Okay, but if not, if this patient ever, I don't know if do you guys do a mock, like a drill for MH every few years?
MH now.
No?
We should, but
Okay. So that's it. So after, if the patient survives, of course, we'll put what under medical record? Allergy to what? All of these here. So we'll put these in their list of allergies. And of course, everyone who sees that will, of course, know, okay, that's malignant, this patient has malignant hyperthermia. So that's why this is listed. Yeah, we don't do the rest because we stop only at malignant hyperthermia. Okay, so this is what I meant earlier was 102. So the limit here, when we cool the patient down, we stop the cooling measures at 102. Okay, once we reach 102, it's okay. We can stop the internal cooling measures. This patient will even respond to just the external cooling measures. Plus, as long as we gave the dantrolene, the muscle should relax and no more heat production. Oh, and every case, by the way, is always reported to the Malignant Hyperthermia Association. No, is it association or foundation? Something like that. So anyway, we report it because it's a rare case and they will investigate each case because are there a lot of these happening? No, very rare. So each case is like gold, like diamonds. So we treat it as a very good source of data. So we collect data, what's the patient's profile. Purpose, of course, is to prevent future. Okay, maybe there's something new here. We collect data so that we can improve our prevention methods.